All right. So I was actually tasked today with talking about the guidelines that were recently produced for preventing COPD exacerbations. Dr. Ouellette lectured on that last year, and the video is available on YouTube still. So we actually talked about shifting our focus to preventing COPD readmission, since it's becoming a quality metric in hospitals in America. Giving you a little bit of background on the economic burden of COPD, it is the third most common cause of death in the United States. And we have 12 million COPDers here in the country. Additionally, there's probably estimated to be about 24 million additional people walking around with impaired lung function, but that do not carry the diagnosis. It's an expensive disease. We spend about $50 billion annually on this. About $30 billion of that is spent in actual direct healthcare expenditure, and another $20 billion in indirect costs, lost productivity, and the like. Exacerbations are common in COPDers. Up to 77% of patients will exacerbate every year and require some sort of health care. Maybe not hospitalization, but still a high number of people that are bothered with this. And the mean cost per hospitalization, at least for an index hospitalization, is $7,000. If you want to divide it by gold category, you can see that people with mild disease or gold category 1 have a mean cost of about $1,681 per year, but that goes up with every gold category. While the medication costs, outpatient, stay relatively stable, which is listed in blue there, you can see that the non-medication costs and hospitalization costs especially go up with every gold category. Unfortunately, the most severe patients we don't have any recent data on, but we can all expect that that's an even higher cost than what you see there. Gold category 3 people cost about $10,800 per year for their care. So in terms of readmissions, what do we know about this? For a long time, we've seen about a stable number of 20.5% of COPD patients that are hospitalized for exacerbations will come back within about 30 days. Every time they get readmitted, there are increasing costs for each subsequent admission. I just told you that the index cost was $7,100 for the first admission. Rehospitalization costs go up with every subsequent hospitalization and can range anywhere from $8,400 up to $11,100. It's obviously a big problem with the Affordable Health Care Act coming out in 2010 that CMS acted as part of this act to put forth the Hospital Readmissions Reduction Program, or HRRP. And this was set out to cut a 3% reimbursement penalty for hospitals that exceed their expected readmission rates. There's a timeline of these procedures, and the first ones that came out were acute MI, CHF, and pneumonia. And as time went by, they added on more diagnoses. You can see in 2015, COPD exacerbations were added to the list along with total knees and total hips. And then in 2016, we're adding additional pneumonia diagnoses, aspiration pneumonia, and sepsis. And coming soon in the future, for any of us taking care of CABG patients in the ICUs, once we go out into practice, that will be a huge metric as well. Readmissions should be defined as any cause readmission. They don't have to come back for COPD, acute MIs, don't have to come back for procedure-related problems. And there are two very small exceptions. Readmissions over 30 days for planned procedures. For example, if someone comes in with an acute MI or a non-STEMI and staged intervention is planned, bringing them back within 30 days does not count. And then also readmissions for chemotherapy and readmissions on day 0. So if you're going to have an exacerbation and leave, you may as well come back come back that day. Anything after that, all bets are off the table. Now, this is hospital reimbursement overall. This is not yet affected physician reimbursement directly, but hospital services can have direct effects on physician reimbursement, especially with the way economics are going in hospital employment for physicians. On top of that, anyone can find out this data for any hospital. This took me 5 minutes to find. You can set all sorts of parameters here and figure out readmission rates for specific diseases, for all causes, any hospital you want that is associated with Medicare billing. So this is all public information. Now the challenges in curbing COPD readmission are many. We know that COPD admission length of stay has decreased over the past couple of years. However, we've actually seen no net change in actual index admissions. Readmissions are dropping over multiple diagnoses, but in a very mild amount after the creation of this act. But there's an unclear effect on patient outcomes. There is some data that readmissions may be protective for some diseases. Again, prior to the creation of the program, CHF was one of the original diagnoses. There was extensive literature on how to prevent readmissions for that disease process. However, we have no such high quality literature at the time that this was all enacted. A 30-day outcome was not exactly a primary outcome in any of the studies, and we have no guidelines either. So where do we start in trying to curb these readmissions? And these are kind of the objectives for today's lecture. What I want to cover is what studies do we have to figure out who's likely to get readmitted when they're still in their hospital bed, to isolate these people and do anything we can to prevent them from coming back within 30 days here. We're going to look at some of the interventions that we know have some evidence of benefit or that can be reasonably extrapolated to benefit. And then we're going to talk about some promising interventions that may decrease readmission. So the first article that I want to talk about in terms of demographics of people that get readmitted was published last year in Chest by Tina Shaw and colleagues, called Understanding Why Patients with COPD Get Readmitted. And what it was is an investigation of Medicare claims data over several years in 7 states from 2006 to 2010. The data that they pulled came from California, Florida, Illinois, New York, Ohio, Pennsylvania, and Texas. So that's a pretty diverse population across the country, representing about 42.5% of the entire Medicare population. They went through 26,700,000 admissions over the study period, and almost 1 million were found to be indexed COPD admissions. There was a small but significant increase year over year from 2006 to 2009, but that's before the HRRP was created. They found that most of these patients were discharged home without any sort of home care, 60.4%. The rest of the patients will group together and call them a post-acute care group. 19.1% of these patients went home with some sort of home care, and another 14.1 patients went to skilled nursing facilities. What she found was that 20.2% were readmitted within 30 days. That goes back to that number, so 20% is going to keep coming up over and over again today. That number is consistent with previous studies and actually everything that's contemporary too. Interestingly, 6% of patients came back by day 1, a third came back by day 7, and 60% were already back within 2 weeks. To put that visually, this is one of the most important slides in the lecture. If you guys can commit this to memory for the next hour at least, it really speaks to me in terms of how quickly people come back. And you can see the 6% by day 1, again a third by day 7, and 60% within 2 weeks here by day 15. So in terms of why people are getting readmitted for COPD, it's important to know that COPD is another exacerbation, in other words, is the most common cause for readmission. But in other words, most people don't get readmitted for a COPD exacerbation. It's the most common cause, but only 26 or 27% of the time. Interestingly, CHF comes up about 6.2% of the time, and that almost makes you wonder if the initial diagnosis was correct. Only half the readmissions are due to any respiratory cause whatsoever. Depending on where you go, depends on if you come back and why you come back. If you go home without home care, you're more likely to come back with COPD, as opposed to any other sort of post-acute care. That makes me at least question, is there an enhanced administration of these medications when you have some sort of supervision, either at home with home care or in a skilled nursing facility? But interestingly, any sort of post-acute care is associated with a net increase in readmissions. So more of these people come back more often, but less often for COPD. Does that make sense? Looking at exactly why people come back, you can see that COPD covers kind of the majority of all-cause readmission here, with about 27%. Let's consider the top 5 diagnoses here: COPD, respiratory failure, pneumonia, CHF, and asthma as respiratory causes. That again covers less than half of all the reasons for readmission. I'm interested specifically in this asthma coming out 6% of the time or almost as often as CHF. You put those two together and it makes you question whether the index diagnosis was correct. or really what the difference between COPD and asthma exacerbation is, and how they figured that out, or if they did. So in terms of the people that they looked at, again, many cases, almost 1 million cases, the index admissions actually match the typical Medicare demographic, which we can conceptualize as a 74-year-old white female. Although it is important to point out that COPDers in the Medicare population have a higher dual eligibility for both Medicare and Medicaid compared to the general population of Medicare patients without COPD. In other words, COPD patients are more likely dual eligible, 26.4% of them, compared to the general Medicare population, only 12% are dual eligible for Medicaid. Most of the patients have 0 to 3 major comorbidities, and 41% have no other major comorbidities. And readmitted patients were more likely to have concomitant CHF as a comorbidity. That was isolated. So to speak more on the burden of COPD on dual eligible patients, we can see that readmitted patients are more likely dual eligible for COPD specific readmission. These patients come back 30% of the time with COPD versus 25% of the time if they are not dual eligible, specifically for COPD. They have a longer length of stay when they come back, 5 days versus 4. They're more likely to go home, unfortunately, the first time without any sort of home care. However, after their index admission, they end up using more post-acute care with each progressive admission. And this is a matter of concern for safety net hospitals that take care of a higher population of dual eligible patients. Not to beat a dead horse, but these patients are sicker and have less resources and less educated. In keeping with previously cited statistics that 85% of COPD patients will typically misuse their inhalers or not pick them up at all, this is probably more pronounced in dual eligible patients. When you want to compare it to medical noncompliance for CHF, this number is much higher than documented noncompliance for CHF. It seems logical in my mind that picking up a generic water pill versus picking up these sorts of inhalers presents specific burdens for dual eligible patients. And the question is, are these factors beyond the hospital's control? And we'll talk about that in a little bit. Of course. Yep. One more.
Is there anything that's different between dual eligible patients and dual eligible patients other than the socioeconomic status of the list on your first bullet point, and then the standard Medicare patients?
So Medicare patients that are also eligible for Medicaid.
Right.
So that is
it's purely a socioeconomic.
yeah, that's the marker sheet. The obvious concern for the study is the accuracy of the index admitting diagnosis. When you look at MIs and CHF, the first diagnoses that we started to penalize, these are readily diagnosed and based on biomarkers. It's so easy to pull a troponin or a BNP on patients and make that diagnosis along with clinical EKG and other evidence. COPD exacerbations are somewhat more nebulous, and there's some degree of diagnostic uncertainty. And just look at how many people came back with asthma. And then it's difficult to truly quantify if this is an underestimate, which is probably likely, of true admissions or true COPD exacerbations based on the fact that we know there's 12 million COPDers in the country, but another 24 million people walking around with impaired lung function but without a formal diagnosis. Or perhaps there is an overestimate here, again with COPD or with asthma or pneumonia. So it's really hard to say what the true incidence of all of these problems are. Also, we know that many COPD patients have a substantial recovery time from their first exacerbation. 25% of patients are not fully recovered by 35 days, and in the 30-day window, to us in a room full of clinicians, seems somewhat arbitrary in terms of outcomes. Again, we don't have a lot of data about 30-day outcomes. It's usually further out. So the practicality of this gets called into question too. Now we talked about discharge discharge destination confounding the data also. More patients at home without home care are readmitted than post-acute care specifically for COPD, and that makes us question non-compliance. But overall, people that go to post-acute care, whether it's at home or whether it's a skilled nursing facility, they come back less often for COPD, but probably because they're sicker. They're going to have competing reasons for rehospitalization. And unfortunately, the study doesn't even account for the sickest patients that died within 30 days. And for some reason, they included planned hospital readmissions, which HRRP doesn't. So the numbers are off a little bit. However, this is the largest retrospective study that we have. Trying to pick out more demographics of people that get readmitted, an article that was published actually last month in CHEST is by Dr. Singh and colleagues dealing with the Association of Psychiatric Disorders with 30-day readmission rates in people with COPD. What they did was they pulled a 5% sample of all Medicare admissions over a 10-year period from 2001 to 2011. And they compared readmission rates in COPDers without any sort of psychological diagnosis or people with any or some combination of depression, anxiety, psychosis, or drug abuse. So what do we know already about people with COPD and comorbid psychiatric disorders? Up to 55% of COPD patients suffer from some degree of anxiety and or depression. These patients are known to have a greater use of healthcare, whether it be PCP visits, ER visits, or hospitalizations. They exacerbate at a higher rate and are hospitalized with longer length of stay and have an overall increased risk of death. And the authors, of course, hypothesized that any sort of psychological disorder would increase the risk of readmission. So again, they looked at 135,000 hospitalizations that were spread across 80,000 unique patients. All of them were age greater than 66. 30,000, or about 22% of these patients, had one or more psychological disorders. And what did they find? That the patients that were that had comorbid psychological disorders were more likely younger, female, white, non-Hispanic, and had a lower socioeconomic status. They had a higher index length of stay, 5 days versus 4, and they were more frequently discharged to post-acute care. However, at index admission, they did have similar ICU length of stay and use of mechanical ventilation. Looking at the results of the study, what's striking is that COPD patients without comorbid psychological disorders have a much lower 30-day readmission rate than what's published for all comers here, 15.5% versus the usual 20.5%. As you add on psychological diagnoses, going all the way up to depression, anxiety, plus psychosis, that number can approach 30%, which is a huge difference. Trying to explain these findings, we know that depression contributes to suboptimal disease control and noncompliance with therapy, whether it be medical therapy or rehab. There's also thought to be a lack of motivation to seek help and less likelihood of smoking cessation in patients with these comorbidities. We also know that anxiety and panic disorder may lead to a misinterpretation of dyspnea, and that may be a big reason that the anxiety patients come back with a higher frequency. We know that in treating them, there is a lower 2-year all-cause mortality when patients are treated for their depression. However, acute treatment will have an unclear effect at 30-day readmission. We don't know that at this point. Pulmonary rehab does reduce anxiety and depression symptoms with improved quality of life, but again, underutilized in this group. So kind of a summary to go through the demographic of patients that are likely to get readmitted. We covered some of these, I bolded them. Other ones we didn't cover, but it's just too many demographic studies to go through. So bigger risk factors for readmission include Black race and male gender. Comorbidities, a few that we talked about. We touched on CHF. Frailty we didn't cover, but I will in a few of the upcoming studies here. Other comorbidities. We know about psychiatric diagnoses, and we know about an increased risk with an increasing number of these conditions listed above. Any discharge to post-acute care is also a risk factor. Dual eligibility, and then markers of advanced disease. Elevated PCO2 levels, low BMI, longer length of stay and previous admissions all increase the risk of readmission. So what interventions do we have, at least in the literature, that we know are that can possibly help here? Interventions that do reduce admissions, and we're going to cover next, are patient self-management, inhaler device training, and early outpatient follow-up within 30 days of discharge. So the first topic to cover is patient self-management. And I want to cite a recent Cochrane review. This is from 2011 by Dr. Zwerink and colleagues. This goes over 29 different studies regarding self-management. And what they did was that they focused on different studies that had some sort of self-management objectives, focusing on COPD disease process, action plans, exercise, nutrition, smoking cessation, coping techniques, and medications. The various interventions were all associated with improved healthcare-related quality of life based on a St. George Respiratory Questionnaire, and improved dyspnea based on MMRC, and seemed to decrease respiratory and all-cause hospitalizations. It remains unclear if these interventions have hyperacute effects and can actually decrease 30-day readmissions. Now, in keeping with the COPD guidelines that were published last year for reduction of all exacerbations not at 30 days, putting these things in separate little vacuums is not recommended. However, an approach that includes multiple objectives from here is recommended overall to decrease COPD exacerbations. However, we don't know what effect it can have on 30-day readmissions. Looking at pre-discharge bundles, this was thought to work in CHF literature, so why not COPD? Could it be translated over? One of the studies I want to cite is a pre-discharge bundle for patients with acute exacerbations of COPD to reduce readmissions and ER visits. This is done by Dr. Jeff Jennings and colleagues and published in Chest in May of 2015. And what they did was they looked at 172 104 patients between 2010 and 2013. They randomized them either to a standard discharge process or to bundled discharge with smoking cessation counseling, screening for gastroesophageal reflux disease, depression, anxiety. They also gave standardized inhaler teaching and made a phone call at 48 hours to reinforce all of these measures. The endpoints that they were looking at was 30 and 90-day readmission rate, which was modeled after previous CHF discharge bundles that were found to decrease readmissions. The study included COPD patients that were greater than 40 years old. They had to have a greater than 20 pack year history. And this is in contrast to other studies that included patients with at least a 10 pack year history. They had to have a previous diagnosis of COPD based on spirometry within the last year or positive findings on a validated questionnaire. The intervention group received a 60-minute visit on the day of presumed discharge to discuss COPD risk factors. And if they were still actively smoking, they were enrolled in tobacco cessation. Again, they were screened for the comorbidities that we talked about in the last slide. A call was made after 48 hours once they went home to review the information again. What they did, they screened 1,225 patients and got 172 in the trial. However, it was stopped early for a lack of treatment effect. What they found is that intervention patients were getting readmitted at a similar frequency over 30 days. However, they were readmitted earlier. Questions with the study is that management of comorbidities were deferred to the primary team at the time of discharge, and it's really unclear if more intensive management by the investigators would have led to significant differences. Overall, looking at multiple studies of post-discharge or pre-discharge bundles in COPD patients, there's a lot of mixed data on this. We questioned the intervention in a 20-pack year history patient, which was seemingly more specific for diagnosis, however, makes these patients probably more severely ill than the other studies. Some, but not all of these studies that we know about are somewhat more successful in keeping people out of the hospital, but seem to have much more intensive interventions. These can last into 7 days, daily phone calls every day for 7 days. And there's a benefit there, but this intervention here seems to kind of closely match what we can do practically, at least in this environment. We know that the patients are applicable to our practice at least.
But I do think it highlights what you just said, that what we can do feasibly without additional resources
Exactly.
doesn't prevent the readmission.
Exactly.
And so if they want to help prevent readmission, they have to throw money
Right.
or resources.
And that's what the other studies are finding. If you can find people to call every day, make sure you're getting through to people, and we'll talk about some other sort of discharge interventions that can be done. Practical, maybe not so much. but successful. Next topic I want to cover is inhaler teaching. We see kind of a heterogeneous sort of inhaler teaching depending on how much time people spend teaching inhaler usage and who does it. So what we know is that, all of us know, is that patients and their pulmonologists probably overestimate their inhaler technique. There's evidence of misuse in about 86% of patients. What we all learned as fellows when we sat down with Amber is that we're all terrible at using inhalers, and trying to expect our patients to do any better is probably a pipe dream. What's the best way to educate people into using inhalers with good technique? Valerie Press and colleagues has 2 different trials out. The most recent one is going to be published in the Blue Journal pretty soon. And what she demonstrated over these 2 trials is that using teaching was just sort of a method. Here's a piece of paper, here's how to do it step by step, versus actual teach to goal, using different techniques to make sure that the patient is giving you teach back methods and all that. It actually leads to pretty promising results. Interestingly, the patient's technique by 30 days does waver somewhat. However, there is an 8-fold decrease in 30-day healthcare utilization, either ER or readmission. There's definitely a decrease in death also at 30 days. Rather than combing through these articles, let's just kind of take a quick look at what we do here. And we know that Amber's using the vein monitor, this Vitalograph, to assess patients' technique. And this is more in keeping with the actual teach to goal method. So where they start is that there's 3 criteria that are determined with adequate technique. Number 1, respiratory rate. Number 2, the inhalation time. And number 3, the breath hold time. Amber can see this, and the patients can see it, that they get a red, an orange, or a green. Green is good, drug is getting down to the lungs. Red is bad, it's staying in the back of the throat. They have 3 different settings, so you see they can hook this thing up to either an HFA inhaler, or dry powder preparations, or they can hook up a spacer too. Anything new with, or I'm sorry, is this applicable to like elliptas and all the new stuff?
Not for the rest of the
And that's what's asking. Yeah. Okay. When we refer patients to Amber, what exactly is going on in her office? I was wondering, at least. So we send them to Amber to be evaluated using the vein device. Based on the technique, the patients are taught specific instruction to try to improve the technique with the inhaler they're on. Some are able to do it, some can't do it to save their lives. And at that point, we find, is there a better device that could be used? And oftentimes we see that. At that point, a recommendation is made to change the inhaler device. Additionally, with this service, Amber and her team are calling the patient's pharmacies to make sure that the prescription's picked up. They make calls to the patient themselves at 1 week and 4 weeks to make sure the teaching is reinforced. Honestly, I've had a great success with this, and everyone I see nodding. This is a major change over the past year. Mm-hmm. Of course. Our next topic here is early clinic follow-up. And the question is how early, with whom, can actually cut down on readmission rates. I want to focus on a Mayo Clinic study that came out pretty recently. This is post-hospital follow-up and 30-day readmission rates in chronic obstructive pulmonary disease. This is done by Dr. Fida Hussein and colleagues, published in Risk Management and Healthcare Policy back in May of 2014. And what it is a retrospective review of Mayo Clinic patients, about 7,000 of them, with COPD who are screened for recent admission. So we have a cohort of COPD patients. Have you been admitted recently? What they found, in fact, is that 839 of those people had recently been admitted, and with 1,422 distinct discharges. They then went on to see, of all these discharges, who went to go see their doctor or their pulmonologist within the next 30 days. 68.4% had follow-up with either their family doctor or their pulmonologist within 30 days. And what they found is that follow-up did not significantly reduce 30-day ER visits or readmission, but there was a significant effect on 30-day mortality. The study does not stratify patients by their COPD severity, and the authors, in fact, talk about further study needed to follow up these high-risk patients. I guess what to take away from this is that there is a protective effect from seeing your doctor after a COPD admission. My question is, with my practice habits, as often as I see people that get readmitted to the hospital in the clinic, I question what effect actually going to see the doctor has. And are we inflating the number of rehospitalizations simply by seeing these patients in the clinic? And where do they end up if they don't? So again, hard to really take a good look at those numbers. Another study looking at this kind of in a different way is the association between hospital readmissions and pulmonologist follow-up visits in patients with COPD. This is done by Rachel Gavish and colleagues, and it was done, published in Chest in August of 2015. A little bit different study, and what they did was they looked at Israeli patients retrospectively. About 195 of them were recently admitted for COPD. What they looked at was how many of these patients were given pulmonary follow-up, as in a recommendation and an appointment was set up in the discharge letter to follow up with a pulmonologist. The lack of follow-up was associated, number one, with the distance that they lived from their pulmonologist, but number two was associated with a higher 90-day readmission rate and mortality. So we covered that. Inclusion of a written recommendation to see a pulmonologist in the discharge packet is associated with improved attendance and thus better outcomes. Now again, we looked at 90-day readmission, but the point that she makes is that just making the organized follow-up seems to have better outcomes here. This is somewhat different in Israel. It's a smaller country. It's socialized healthcare. And number one, it's hard to compare health systems. And number two, there's certainly accessibility issues to get in with your pulmonologist. Consider the graph one more time here, where most of these people are getting readmitted within 2 weeks. Is it really likely that our patients can get in to see us in 2 weeks? And that's something that we all have to think about as physicians. Let's look at one last study design on the same topic, and this could be outpatient follow-up visit and 30-day ER department visits in readmission in patients hospitalized for COPD. It's done by Dr. Sharma and colleagues. It's published in the Archives of Internal Medicine in October of 2010. What they looked at was 62,000 pulmonary and PCP established Medicare patients that were hospitalized with COPD from 1996 to 2006. These people had to know their doctor. They had to see them at least 3 times in the last 2 years and were able to get back in to see them. What they found was that 66% of these patients that were discharged with a COPD diagnosis were able to follow up with either physician or both within 30 days. But importantly, 3/4 of them saw these doctors within 15 days, again, when the majority are about to get readmitted. What they found is a decreased incidence of ER visits here, 21% in the follow-up group versus 26% in the group that was not followed up. And a decreased 30-day readmission, again, approaching significance, 18.9% versus 21.4%. Moving on to interventions that we think may help. There's a few. The ones that are in bold are the ones that we're going to cover, but there's quite a few here. Pulmonary rehab, telemedicine, receipt and filling of respiratory medications prior to discharge, pharmacy supervised medication reconciliation. We'll talk about some drugs. And lastly is the question of can we be treating these exacerbations at home and keeping people out of the hospital to prevent index admission. In terms of pulmonary rehab, we know that there's benefits with regard to exercise performance, functional status, and healthcare use. There are guideline recommendations in the prevention for acute exacerbations of COPD for pulmonary rehab pretty early, not months down the road, but within the 4 weeks after an exacerbation. It's unknown if pulmonary rehab actually has an effect on 30-day readmissions. What I can tell you is that in a recent Cochrane review, again done in 2011, 5 small trials do show a trend toward decreased hospitalization at 3 to 9 months after index, but again, 30 days is still up in the air. And we know about mortality benefit after index admissions too. The question is, how soon is too soon? You go back to the graph of the readmissions, how are we going to get someone into pulmonary rehab, especially in this environment, trying to get them in within a week, within 2 weeks, to try to prevent admission at 30 days? Is that possible? And when's the right time? We do have an article that answers this question. It was done in 2014. It's called An Early Rehabilitation Intervention to Enhance Recovery During Hospital Admission for an Exacerbation of Chronic Respiratory Disease, a randomized controlled trial. Randomizes has an S in it, therefore it was done in Europe. This is done by Dr. Greening and colleagues. It's published in the British Medical Journal in July 2014. What she looked at was putting people into pulmonary rehab within 48 hours of admission versus usual care. So you have 389 patients with acute exacerbation of COPD that were screened and enrolled within 48 hours of their index admission to start inpatient pulmonary rehab versus the typical sort of PT-OT evaluation and discharge recommendations. The primary outcome was readmission at 12 months, and the secondary outcomes included length of stay, mortality, and health status. Unfortunately, we're not looking at a 30-day outcome here. What she found was that with early pulmonary rehab, there's actually no difference in hospital readmission here at any time. Strikingly, more of the early rehab people died at 12 months. They don't have an answer for that, but it is significant. The line seems to cross or diverge at about 6 months here. So again, 25% versus 16% in the usual care group. The authors question alterations in health behavior that might modify their response to subsequent illness. However, give no further sort of hypothesis as to why this might be happening. I believe the majority were. I didn't write it down, but when you go back to the CHEST guidelines, this I kind of touched on briefly, is that there is a recommendation of putting people in pulmonary rehab after a recent exacerbation within 4 weeks. Exacerbations greater than 4 weeks, they do not suggest pulmonary rehab to prevent another acute exacerbation. And this makes sense, but now we have data that says that a hyperacute intervention could be dangerous down the road. So in terms of pulmonary rehab, still have not answered that question. Let's talk about pharmacy supervision. We talked about good inhaler technique, and perfect inhaler technique would be great, but we need to make sure that patients actually have the inhalers to go home with to use them, even suboptimally. Here's a study looking at actually sending the patient home with their inhaler that they get in the hospital. It's called Dispensing Inhalers to Patients with Chronic Obstructive Pulmonary Disease on Hospital Discharge, the Effects of Prescription Filling and Readmission. Done by Dr. Blee and colleagues. This was published in the American Journal of Health System Pharmacists in July of 2015. This is a study that was done in Sugarland, Texas, which sounds sweet, but it's actually an inner-rig suburb of Houston with a 64% lack of prescription coverage. What's that? Your peeps? All right, good. Applicable to your friends. Let's look at it. All right, so what they did was they identified inpatient COPD exacerbations. These people had to be on Advair or Symbicort. And what they did was that both drugs were on formulary in the hospital. They dispensed the inhalers to the patients. And then they sent them home with the inhaler as long as it had more than 7 days left in it. What they did was they assessed adherence rates and 30-day readmissions. They looked at 620 patients. About 400 were in the pre-intervention period, 208 were in the post-intervention period. The trial was actually stopped early due to a larger than expected improvement in rehospitalization rates that we're going to look at in 1 second. Pre-intervention, 21.4% of patients were readmitted, goes along with the numbers, down to 8.7% readmitted at 30 days when they go home with their inhalers. If you look at adherence, they assumed it to be 100% because they defined it as calling the pharmacy and making sure that the patients filled their prescriptions. So that's all. You own the drug by 3 days. You send these patients home with a script for the drug. Only 55% of the patients actually picked up the medication. 100% all have inhalers with at least 7 days worth to get them through those first 7 days where we know that 30% are going to come back. Interestingly, their 60-day readmission rate was significantly lower too. If you can get these people stabilized on an inhaler, they may like it so much that they may refill it even down at 60 days. The patients were more likely to refill despite this population of low prescription coverage. Interestingly, sending people home with their own inhalers that we were going to throw away anyway saved the patients $20,000. Also saved the hospital $500 because you can't just throw them away, you have to dispose of them properly. So again, looking at this time to readmissions, this is a hyperacute intervention that could be made. This makes sense to me, that sending people home with their inhalers and not missing doses gets you through this first week where we know that a third of the patients are going to come back. If they're more likely to refill the medications, they're going to get through the next couple weeks too. Talking about medications that we know might help. So each component of triple therapy has been well studied, and there's guidelines on all of these things. Addition of these drugs at the time of discharge really has unclear effects on 30-day readmission rates. I don't want to cover that too much. We want to assume that the patients are all well treated based on their severity of disease with inhalers. But what should we do after patients are optimized on their regimens? There are a few drugs that we know about. We know Zithromax is known to decrease exacerbations over a 12-month period, but it's still unstudied in terms of 30-day rehospitalizations. And it's questionable whether starting someone on this medication acutely might have such a short-term effect. It's unclear if theophylline would have any effect on rehospitalization. Again, the hospital setting might not be the best place to start this medication, and it's going off the market, so we're not going to look at it. We talked about Zocor in the past having promising decreased incidence of exacerbation in retrospective studies. However, this was not reproduced in a large prospective trial and was not recommended by the CHEST guidelines to decrease exacerbations overall. What drugs can we talk about? We know that Dalaresp is known to decrease exacerbations in certain phenotypes of patients over a longer period of time. A question asked by Dr. Alex Fu and colleagues and published in the International Journal of COPD in May of 2015 was, would we see lower 30-day readmission rates in patients that were treated with Dalaresp for COPD? And what they looked at was a chart review of insurance claims over a year period for COPD admissions. Out of 15,755 index admissions, obviously a very small minority were using Dalaresp, about 2.3%. But they had to be using it within 14 days after the index admission. Interestingly, all-cause readmission for people on Dalaresp was only 6.9% versus 11.1%. This is not in keeping with the numbers that we saw before, where we're used to seeing about 20%. So I question the population. And interestingly, the majority of your Dalaresp-treated people are readmitted for COPD, 6.3 out of 6.9%. Versus this 9.2 out of 11.1%. Nonetheless, in the CHEST recommendations, they do suggest for moderate to severe COPD with the chronic bronchitis phenotype and at least one exacerbation over the last year, they do suggest the use of Dalaresp to prevent acute exacerbations of COPD, grade 2A recommendation. You can see that all these studies do favor the use of Dalaresp. However, they make the caveat that you may have to discontinue this drug because of the high incidence of both GI and depressive side effects. Again, their data does not really look at people on additional inhaled therapies. Looking at N-acetylcysteine, we know again that this drug may have an effect of reducing COPD exacerbations. And in this article published in the European Respiratory Journal in May of 2003, looking at rehospitalization. So what this study did, this is an old study I have to point out, they looked at 1,200 patients with an index admission anywhere from 1986 to 1998, and they followed them for an average of 276 days. The use of oral N-acetylcysteine was associated with a significantly decreased rate of readmission. The relative risk was 0.67. However, I would question regarding our current practice. There's a lot of patients that were still on theophylline at the time, and few of them on these longer-acting inhalers. In fact, looking at things from the 80s, I question what inhalers were even available at that time. So we can see that COPD treatment is much different now. Nonetheless, you can see the Kaplan-Meier curve, even at 30 days, shows quite a marked difference. And again, CHEST recommends, yes, sir.
So if you show a meta-analysis, the last article is meta-analysis.
Right here.
Yep.
Yep.
That's a very recent article.
And still favoring the use of, right.
I was trying to, from
There you go. The question is with N-acetylcysteine, it's kind of a nutritional supplement. Where are we going to get it? How are we going to standardize it? And how are we going to make sure everyone's getting the same drug? That makes this difficult. This is Amazon.com. Obviously, if you're on Amazon Prime, you can get many of these drugs in many different dosages, formulations, to your door within 48 hours, or actually by yesterday. Okay. The question remains: is this going to be an effective drug to decrease? I beg your pardon? Oh no, I have no disclosure. I am not an Amazon Prime member. I should, yeah, I mean, look at these benefits here. On the topic of nutritional supplements, I just want to wrap up and talk about this last intervention. And we know that our COPD patients are at a high risk of nutritional deficiency. This impairs their respiratory muscle function and possibly their immune function, make them more frail, which is associated with readmission. The question that Dr. Snyder and colleagues asked and published in Chest of June 2015 is what effect would hospital use of oral nutritional supplements have on the length of stay, hospital costs, and 30-day readmissions among Medicare patients with COPD. And what they did was they reviewed Medicare patients admitted for exacerbations. They isolated the people getting oral nutritional support and matched them against a control group to compare their length of stay, their cost, and their 30-day readmission rates. What they found was that oral nutritional supplements were provided to a vast minority of patients. Only 2.7%, about 10,000 of 378,000 patients got oral nutritional supplements. I don't know if this is really in keeping with our practice habits. I feel like we're a little bit more on top of this. This does exclude tube feedings, by the way. The supplemented patients were more likely to be older, and they're more likely to have had a previous admission in the past 6 months. Hospitalizations for patients that were supplemented were much longer, 8.8 versus 5.2 days. They were much more expensive, 14,000 versus 7,000, and they're more likely to be followed by a readmission. Obviously, these people are sicker. However, when you actually match these people one-to-one with their nearest comorbid control neighbor, length of stay and cost difference remained. However, there was a trend towards a decreased readmission rate. 24.8% versus 26.6% of patients actually receiving oral nutritional supplements in the hospital were less likely to come back to the hospital compared to someone who didn't, who is just as sick as them. Does that make sense? Okay. Unfortunately, more supplemented patients were lost to follow-up because they're sicker and they may have died either at home or outside facilities given their greater severity of disease. Other exciting areas of research that we don't really have time to cover today include telehealth care, making calls to people we talked about, both in pharmacy studies and post-discharge follow-up studies. Who should be making the call? How often should we be calling? All of these doses, these intensities of telemedicine to really work is still kind of up in the air. Pharmacy participation and medication reconciliation is exciting. We like to all think that we're great as physicians at discharging patients, and we know we're not. That's why these people come back with CHF, and that's why I see patients in the clinic very often that get readmitted for volume overload because someone didn't discharge them on their diuretic. This, at least logically, seems like it has some promise to it. Next question is, can we be more judicious in treating people at home for their COPD to prevent that index admission, or to prevent exposing them to the iatrogenics of the hospital? And then I think what's going to come out in the future here is the unintended consequences of this program. What's going to happen to people that we're really trying to keep out of the hospital if hospitalization may have a protective effect? We know that patients that have CHF decompensations that come into the hospital, that come back within 30 days, actually die at less of a frequency. Hospitalization or repeat hospitalization has a protective effect on these patients. Are we going to miss out on that on COPD patients? Can a COPD patient recover within 30 days? And is a 30-day target really feasible for following quality metrics? Are there ways to game the system? Can we call them bronchitis? Can we observe them for 48 hours and send them home to prevent that index admission? There's going to be a lot of unintended consequences with this that are going to come out too. These are my references. There's more. Any questions? Sir.
This is a question for your Brian or Amber or Dr. Morris. Is there, I mean, when patients follow up after teaching for inhalers, is there a role for reteaching at every visit or so?
Absolutely.
Is there doubt into that?
Yes.
Absolutely.
So the literature shows that after about 90 days, no matter what teaching you do, about 40% of them fall back to their normal habits, and by 6 months, it's down to 80%.
That includes doctors and residents and staff that are taught how to do it also, to go back and have them explain to you again without the same follow-up or introduce.
So reinforcing education is very important.
Pretty much in our clinic routine, we have the nurses after I talk to the patients a little bit, have them tell me a little bit what they're doing. I usually have the nurses come back in before the meeting again every day. Talk to the patients, get them instructions.
Dr. Ouellette,
I used to
Dr.
think that was age-related, but it's not. We got
No.
people who do something.
There's a lot of ways that asthma, but then you can-
Mm-hmm. Dr. Ouellette?
I was just gonna say that when my son was young, he asked me to have a conversation about the Civil War. And he asked me about what it was like back then. That kind of reminds me of your comment about the 80s and talking about how things were different. And the depressing thing is that they weren't, that it wasn't that different. And so, being a resident in the mid-80s and a fellow in the late 80s, we prescribed albuterol and we prescribed corticosteroids and we gave oral corticosteroids and antibiotics and things like that. By the late 80s, we had ipratropium and Theophylline and the NAC were things that we were about too. And so, unfortunately, even though we have all sorts of increws and, you know, meclidinium and glycopyrrolate coming out, these are Me Too drugs. And it's depressing to see that we really aren't doing anything different. And this is a field that my commentary is that really demands some novel approaches and novel ideas. Because we haven't had it. It's really not that good.
I think the powdered inhalers, like the rest of that, they're probably one of the best things that have happened to our field. But the problem is, a lot of these powdered devices, you have to be able to generate really high flow. Unlike a meter dose inhaler, you can inhale slowly over 5 seconds. With a powdered inhaler, you have to suck it in. If you look at the flow characteristics of studies, a lot of these patients with severe end-stage COPD cannot generate the flow that's listed in, in their testing to make them work properly. So that's the other side.
Luckily, that's one of the things that Amber looks at when she tests patients.
Yeah. I was gonna say, you know, when we test our patients, we make those clinical decisions, and then that's why we talk with the providers and we'll say, you know, based on the testing that we've seen, the patient does not have flow rates, and really where they're at in their disease state, the only recommendation is to look at to push them to NEBs, because then at least we know that the NEBs will get more into the lungs, more penetration into the lungs than any other inhaler device will.
Great. Dr. Tatum, Dr. Bowles, Dr. Chabon.
Yeah, that was actually my question, Andrew, is whether or not, because we know of the dismal compliance with inhalers, whether or not there's any literature that has been published on whether or not patients who get nebulized medications actually do better, and whether we should be shifting our focus really towards nebulized medication and getting ourselves out of this sort of professional use of these inhalers.
Currently, there is no literature, but that's Emily's project next year.
Well, you know,
at least internally, we'll look to see do our patients do better when we recommend a system to nebulators versus we're going to just compare satellite groups where we don't touch those patients as much and see if they have the same results but are not switched to these patients.
If you don't know, why don't you actually study it?
No, I'm
Well,
always
you
going to do
don't
that
know,
next
why
year.
don't you, I mean, so the idea is, well, they don't have good flows, so they should be on nebulized. So maybe what we should be doing is if they don't have good flows, we just do nebulized.
Well, you know, we do have literature on that indirectly, that most of the nebulizers are 4 times a day, that, the dual nebs, albuterol. Nobody does anything 4 times a day, and I think any patient for the last 30 years that's put on a neb 4 times a day because they can't afford anything else, is never taking it 4 times a day. You're likely to get 2 on a bad day, maybe 3 times a day.
But the other thing is we never had long-acting beta agonists.
That was my next comment, though. There's like a few insurances that cover long-acting, like for example, Rovanas, $1,200 a month. No insurance covers that. We put on Medicare Part B for these patients, but none of the other insurance covers. Homoport in the lower doses, now that it's gone generic, 0.5 will do that. The 1 milligrams, 800 milligrams. So nobody's covered that either. So, you know, we're stuck with a short active because there's an insurance in the world that's gonna pay $2,000 a month for the nebulizer.
Dr. Bowles.
How many of us don't do MDIs? How many of you?
Of the fellows, I can tell you it's like
I mean-
less than 20%.
When we graduate, at graduation, can we watch Dr. Morris use the vein monitor?
Well, let me tell you a story. I'm part of the asthma coalition. I used to teach MDIs, teaching and stuff like that. So one day there was a guy from Bernard, the lead academic. They would come down to F2 and they do the MDI and stuff for all the F2 residents. So one day I was standing by myself and no one was doing it. I go, come test yourself. I go, how dare you? That's me. You know who I am. Yeah. Well, so he said he begged me to come in to do the MDI test. You know how many times it took me to get the red light or whatever, the green light? 8 times. It's embarrassing. And there's somebody else in a high position here in the institution who took them 10 times. So it's very difficult. So after that, I said, oh my God. So I think we ought to all be taught. Which is one of the teams teach us all how to do that.
Every one of my fellows, every year, when they start new, I go into the patients who runs on inhalers, and we go over it step by step. Like, you know, I know how to do it, but I do it for their benefit. Now, when we go through step by step with the patient, I have them start to demonstrate. If I don't like what they're doing, I stop them in the middle of it. And, you know, it's a laborious process. But, you know, most of my fellows know how to use meter dose inhalers because you repeat them over and over again.
It only lasts for 3 months. Well, we teach them again.
And one of my first questions, right, and one of my first questions to them when they come back is, hey, listen, did you have the patient demonstrate you say they're not doing so good? Did you have them show you how to use your inhaler? And most of the time they say no, so we go back in and I do it again with them.
Doctor.
Thank you for the lecture, Ryan.
You're welcome.
I have a question. Have you come across any literature talking about the use of in the chronic hypercapnic with the ears, them being discharged on cath therapy?
Yeah, I didn't go that far. Sir.
There's not a lot on that.
No, I'm
It's
just
an abstract at
Why?
yes, but not, there's not a whole lot out there.
It's more like a problem. I feel like when all these especially with the very COPD, something that we don't know what is happening, so that sometimes it's where they are in charge. So that not only the COPD, but
Right.
sometimes they are started too early, but they are in charge level up. For example, the amount of oxygen that they need to get from. So they are so good positioning that you know they can reduce when they are sitting and lying on the bed, but you know, they can walk now. These are the supplements in the bed and taking that while you go to bed. So we usually don't take for people who can take in the house.
Definitely.
Like the story about one patient we have from Boston.
It's something that you can just simply walking on. It doesn't even tell you around, oh, they're still miserable, they're still using, or they need PRN, or I don't know what they're talking about. It's just you walk, so the patient get up and walk, yeah. And what's their baseline? And it's like, yeah, answer the question, you have no idea if the patient, how much oxygen and do they need. So there's simple things that we should be asking. I think that we kind of miss. I think one of the things, because it's
I
such a
gotcha.
broad topic that Brian, touching on.
Yes, the question.
We have standard things that are done now, and Dan can probably comment more than I can on this, but I know, as part of, because we were worried about the medication people that was generated by it, and I think more that it was just random, medication reconciliation at pharmacy, making sure that patients are getting on prednisone, making sure that patients are left with their medication, home care setup when appropriate. I think that we have now a protocol, at least, and I think we don't realize it's happening. But I think without that, there's definitely been, there's less questions that I have to ask now that no one knows the answer to. At least that those things are in place, and I find that I feel more comfortable with the patient treating because of that. But we actually have, and it's supposed to be hospital-wide, although getting people to take 10 days of prednisone is still complicated. But no, those things are now, like, we started to do a bit more.
Right.
Do you have a question,
Do
sir?
you want to comment on the steroids?
No, please, yes.
Duration?
Oh, I'm glad you asked. I actually made an emergency slide in case someone brought this up. This is a Kaplan-Meier plot from the reduced trial. We know this trial was neither intended nor powered to look at 30-day readmissions for COPD. However, there is at least the hint that the short-term group does get readmitted quicker. Again, this study doesn't do much to tell us that that this could prevent 30-day readmissions. But again, knowing what the graph looks like, knowing when people come back to the hospital, it seems at least logical that treating them out to 10 days, like you had said, Dr. Raja, could possibly cut down on readmissions.
Just so you also, a third of the patients who were in the 5-day group ended up getting into it.
Exactly.
And
Exactly.
So I have a lot of problems that take into account.
Dr. Bowles.
One other comment. So back when I was part of the asthma coalition, we discovered that when you taught patients individually about asthma, the outcomes didn't come out as well as we would like. But there was a group up in Flint around there that was taught families. Everybody in the family learned about asthma and MDI, this and that, and their outcomes were spectacular. Now, I don't know how that would work in COPD, but if we teach other people around them something similar is possible for definitely, it would be nice and